Namaskar. Welcome to the lecture series on food technology. Today, the topic foodborne diseases will be discussed under the following subunits. 1. Introduction. 2. Foods associated with foodborne diseases. 3. Epidemiology of foodborne diseases. 4. Important foodborne diseases. 5. Diagnosis of foodborne pathogens. And at last, 6th, description and treatment. Let us discuss the foodborne diseases with an introduction. Foodborne diseases is caused by consuming contaminated foods or beverages. Many different disease causing microbes or pathogens can contaminate foods, so there are many different types of foodborne diseases. More than 200 pathogens are associated with foodborne diseases. An estimated 76 million cases occur annually, resulting in 3 lakhs hospitalizations and 5,000 deaths. The onset of foodborne disease is generally acute, with a resolution of an uncomplicated illness in 72 hours for most episodes. Proper food handling and preparation, personal hygiene and improved methods of decontamination of consumer products could significantly reduce the extent of morbidity and mortality of this common problem. Foodborne disease can be caused by bacteria, parasites, toxins and viruses. Despite efforts to investigate foodborne diseases, less than 50% of all outbreak causes are identified, usually because of limited diagnostic capabilities. Viruses are likely the most common cause of foodborne disease, but are seldom investigated and confirmed because of short duration and self-limited nature of the illness. In addition, the inherent difficulty of laboratory investigation and subsequent cost of viral studies led to a lack of clinician investigation and therefore overall underreporting. Bacteria are the most common documented cause. Foodborne disease is more likely to affect the extremes of age as well as immunocompromised patients and pregnant women. These groups suffer higher incidence, morbidity and mortality. The effect of foodborne disease may extend beyond the immediate illness. The most commonly identified pathogens are Campylobacter species, Salmonella species and Shigella species. These organisms have evolved and now have greater cold, heat and acid tolerance as well as resistant to multiple antibiotics. Increased drug resistance has been associated with prolonged illness and a greater risk of hospitalization. Let us discuss the second one, foods associated with foodborne diseases. Raw foods of animal origin, that is raw meat and poultry, raw eggs, unpasteurized milk and raw shellfish are the most likely to be contaminated with foodborne pathogens. Fruits and vegetables can also be contaminated with animal waste when manure is used to fertilize produce in the field or unclean water is used for washing the produce. Raw sprouts are particularly concerning because the conditions under which they are sprouted are ideal for growing microbes. Unpasteurized fruit juices or cider can also be contaminated if there are pathogens on the fruit that is used to make it. Any food item that is touched by a person who is ill with vomiting or diarrhea or who has recently had such an illness can become contaminated. When these food items are not subsequently cooked, for example, salads, cut fruits, they can pass the illness to other people. Epidemiology of foodborne diseases. Previous outbreaks of foodborne disease were smaller and limited in scope, more often originated in the home and were associated with Staphylococcus or Clostridium species. Family picnics or dinners and home canned foods were the typical sources for the outbreaks. Today, many people dine outside the home and travel more extensively. As a result, more than 80% of the foodborne disease cases occur. Technology has provided the means for mass production and distribution of food. Therefore, foodborne disease often occurs on a massive scale whereby hundreds or thousands are exposed and may become ill. Mobility and travel have resulted in exposure to foods abroad where regulation of food safety and food products for sale may vary. When traveling, the axiom boil it, peel it, cook it or forget it remains true in many areas of the world. Unique ethnic food preferences and preparation have been associated with several food related illness. One example in the African American tradition of eating chitterlings that are cooked swine intestines during the holiday season. This food has been associated with an outbreak of Yersinia enterolytica infection in infants. Fresh cheese made from unpasteurized milk has been associated with episodes of listeriosis. Almost many food can be source of foodborne diseases. Some foods are more commonly associated with particular organisms. Salmonella has traditionally been associated with poultry and eggs, Campylobacter with chicken and unpasteurized milk. Water may be the vector of illness when contaminated with viruses, bacteria, parasites or chemicals. Crowding, poor sanitation, disruption of water supplies and natural disasters are closely linked to waterborne illness. Viruses are the most common causes of waterborne illness and include rotavirus, enteric adenovirus, astrovirus, calicivirus and hepatitis A virus. Outbreaks of gastroenteritis aboard cruise ships in recent years were as a result of noroviruses. Salmonella species, Shigella species, E. coli and Vibrio species are the predominant bacterial pathogens involved. Cryptosporidium species and Giardia lamblia are the parasite pathogens most commonly encountered in waterborne illness. Immunocompromised hosts, particularly organ transplant recipients and HIV infected patients, should exercise extra precaution in situations of potential waterborne illness. Incubation period of foodborne diseases may offer clues to the cause. 4 time frames may be envisaged: very brief, short intermediate and long durations of incubation. The very brief category, less than 8 hours, is generally caused by preformed toxins which may be found in staphylococcal or bacillus contaminated food. Short incubation period, that is 24 to 48 hours, are more typical of viral causes. Intermediate incubation periods, that is 1 to 5 days, correlate with many bacterial pathogens. The long duration incubation group, that is more than 5 days, approximates the time course of parasitic infections. These time frames are crude groupings and areas of overlap exist between them. In addition, the inoculum of organism ingested may influence the incubation period and the rapidity of onset of illness. For example, a large inoculum may cause a shortened time to onset of illness. Let us discuss now important foodborne diseases. Among that, the first one is salmonellosis. Salmonella is the most commonly identified bacterial cause of foodborne disease. It is estimated that 1.4 million cases occur annually. Fever, abdominal cramps and diarrhea, occasionally bloody in a minority of cases, are the usual manifesting symptoms after 8 to 48 hours of incubation. Although generally self-limited, Salmonella infection may cause sepsis and localized infections such as septic arthritis and infection of endovascular prosthetic devices such as grafts. The most common serotypes are Salmonella typhimurium and Salmonella enteritidis. Eggs remain a common source because of vertical transvarial transmission within an infected poultry flock. Poultry itself has become a significant source of Salmonella infection. Fruits, vegetables, meats and ice cream are other reported food associations. Populations at greatest risk are infants, older adults and the immunocompromised, but also those with inflammatory bowel diseases and endovascular prosthetic devices. Patients older than 60 years have the highest rate of hospitalization and highest case fatality rate. Antibiotic treatment should be considered for these high risk groups because bacteremia may occur in 2 to 14% of cases. Unfortunately, increasing resistance to the usual antibiotics such as cephalosporins, aminoglycosides and fluoroquinolones has made therapy more challenging. Campylobacter infections. Campylobacter is the second most common identified organism in foodborne disease. Over 1 million cases are estimated to occur annually. After 2 to 5 day incubation period, acute dysentery ensues. Nearly 2/3 of patients will have fever and 1/2 will have bloody diarrhea. Illness may last 1 week and then resolve spontaneously. Immunocompromised patients may experience life-threatening sepsis and therefore should receive aggressive therapy. Age-related biophasic peaks of Campylobacter infection occur in infancy and early adulthood. Young men are more often affected because of poor food handling knowledge. Almost all human illness is caused by one species, that is Campylobacter jejuni. Poultry is the overwhelming source. Additional food sources include raw milk, water and ice cream. Shigellosis. Although less common than Salmonella and Campylobacter, Shigella is a significant cause of foodborne disease. Shigellosis is responsible for 10 to 20% of cases of bacterial foodborne illness each year in the world. After 2 to 4 days of incubation, it produces an invasive dysentery syndrome that often includes fever and bloody diarrhea. Shiga toxins are frequently elaborated. Duration is typically 5 to 7 days. Fruits, vegetables and shellfish are common food associations. Third generation cephalosporins and fluoroquinolones are the antibiotics of choice. However, drug resistance may be encountered. Shiga toxin producing E. coli, that is STEC O157H7 infections. Shiga toxin producing E. coli infection was initially associated with ground beef. Multiple other food associations have been recognized, such as unpasteurized milk and dairy products, juices and lettuce. In addition, this has been associated with non-foodborne illness after contact with cattle and swimming in contaminated lakes. An estimated 60,000 to 70,000 cases occur annually, resulting in approximately 2,000 hospitalization and 60 to 70 deaths. The average incubation period is 4 to 8 days. Symptoms include abdominal cramps with bloody diarrhea, but little or no fever. The diarrhea usually resolves within 1 week. Antibiotics appear to play no role in treatment because the illness is result of Shiga toxin produced by the organism. It is more common in the young and older adults. Listeriosis. Listeriosis is caused by Listeria monocytogenes. It is a much less common cause of foodborne disease with approximately 2,500 cases annually. However, it has the highest hospitalization and mortality rates of all foodborne diseases with approximately 500 deaths each year. It strikes more often at the extremes of age, attacking the young and older adults as well as those who are immunocompromised, causing a more severe illness in this population. Pregnant women are also at increased risk of infection. Manifestations appear to vary by host-related factors. Older adults and immunocompromised patients often present with sepsis and meningitis, whereas immunocompetent patients develop gastroenteritis. Pregnant women may experience a flu-like illness resulting in bacteremia, meningitis, or both in the newborn infant. Listeriosis has been associated with meats, breads, soft cheeses, unpasteurized milk, and dairy products. Illness follows a 1 to 2 day incubation period. Clinical symptoms include fever, gastrointestinal upset, and subsequent diarrhea. When treatment is needed, ampicillin appears to be the most effective antibiotic with the consultation of doctor. Vibrio infection. Vibrio foodborne disease tends to be seasonal with a peak incidence in late summer and early autumn. Consumption of raw seafood from coast is the most common food association. Vibrio parahemolyticus and Vibrio vulnificus are the most frequent species isolated. They are halophilic and cold tolerant organisms which allow Vibrio to survive in conditions that may normally retard or prevent food contamination. A clinical syndrome of watery diarrhea, abdominal cramping, nausea, vomiting, and fever occurs 1 to 4 days of ingestion. The illness is usually self-limited with resolution in about 3 days. Person with liver disease may develop a severe sepsis syndrome with 50% mortality. Vibrio cellulitis and wound infections are occupational risk for fishermen and oyster shuckers. Yersiniosis. Yersiniosis is an uncommon cause of foodborne disease. It has been associated with the consumption of raw pork, unpasteurized milk, and dairy products and contaminated water. The preparation, handling, and consumption of chitterlings such as small intestines of a pig, cattle, and other animals has been associated with Yersinia infections. The incubation period is 4 to 7 days and is followed by fever, abdominal pain, and bloody diarrhea. The abdominal pain may mimic that of appendicitis. Additional manifestations include carditis, joint pain, and sepsis. Although most cases resolve spontaneously, severe cases may require medical therapy. Protozoan foodborne diseases. Parasites are an uncommon form of foodborne illness. The most frequent causes include Cryptosporidium species, Giardia lamblia, which have been associated with contaminated water. Additional foodborne diseases include cyclosporiasis, trichiosis, toxoplasmosis, and amoebiasis. Cyclosporiasis has been previously linked to imported raspberries. Trichinosis was traditionally linked to pork but can be contracted through other sources such as inadequately cooked food. Toxoplasmosis has been most often associated with undercooked meat, and amoebiasis is associated with contaminated water. Cryptosporidiasis may be difficult to treat. Foodborne diseases through toxins. Foodborne disease caused by toxins may have a variety of presentations that include gastrointestinal symptoms, neurologic manifestations, or both. Preformed heat stable enterotoxins associated with Staphylococcus and Bacillus cereus have an acute onset of nausea, vomiting, and diarrhea within 1 to 6 hours of ingestion. Fever is not a common component of this self-limited syndrome. Symptoms resolve rapidly, often within 12 hours. Clostridium perfringens has a slower onset of illness, occurring approximately 12 hours of ingestion because the heat labile enterotoxin is produced in vivo after consumption of contaminated food. cramping and diarrhea are the major manifestations with resolution of symptoms in about 24 hours. Botulinus toxin is considered the most potent lethal substance known. It is produced by Clostridium botulinum. Illness occurs 18 to 36 hours after ingestion of the source food. Home canned foods have been the traditional sources. The onset of illness is heralded by nausea, vomiting and diarrhea, followed by constipation. A descending paralysis then occurs. Antitoxins are available but only prevent further progression of paralysis because they neutralized circulating toxins and have no effect on bone toxin. Foodborne botulism carries 5 to 10% mortality rate. If the individual survives, many months may be required before recovery. Marine bacteria present on the surface of some fish produce inhibitors of histamine degradation, resulting in high levels of histamine. When they are consumed, scromboid poisoning, that is histamine fish poisoning, may occur. The syndrome resembles a histamine reaction with flushing, headache, nausea, vomiting, cramping and burning in the mouth and throat. Poisoning by Cigatura fish such as grouper and snapper products produces nausea, vomiting and diarrhea. Shellfish poisoning causes a similar syndrome except that muscle weakness, paralysis or amnesia may occur in severe cases. The neurologic manifestations resolve in hours to a few days. Mushroom poisoning can produce various clinical syndromes. Onset is rapid within 2 hours of ingestion and resolution of symptoms occurs in approximately 24 hours. Organ failure may follow after the additional 1 to 2 days of incubation. Without emergent liver transplantation, acute hepatic failure rapidly leads to death. Viral foodborne diseases. Hepatitis A and Norwalk viruses are the two most commonly identified viral sources of foodborne diseases. Many additional cases of foodborne diseases occur as a result of unidentified viruses. Hepatitis A is often associated with shellfish and infected food handlers. Proper knowledge of food handling, storage and preservation could have significant impact on the occurrence of this common problem. Improved conditions in mass production and processing of foods have produced tangible results. New methods of sterilization such as irradiation represent avenues for future progress. Coming to diagnosis of foodborne pathogens. Diagnosis is accomplished through a careful history, physical examination and laboratory evaluation. The history should include questioning about the suspected time of exposure, recent travel and food and drink consumed, other people who may also been present and eaten similar foods and the specific symptoms involved, for example, nausea, vomiting, diarrhea or with or without visible blood, cramping, gas, fever, neurologic symptoms, alteration of mental status. Dietary history may include intake during the last 2 to 3 weeks. The physical examination should focus on vital signs including orthostatic measurements, skin turgor, mental status, abdominal findings and stool testing for blood. Fresh stool samples of culture and analysis less than 6 hours of old provide the highest yield. The clinician must be knowledgeable of the laboratory assays procedures to facilitate proper sample testing. Specific culture requests for suspected organisms may be necessary as well as microscopic examination of stool samples for parasites. 3 samples on different days will generally provide adequate diagnostic results. Special circumstances may dictate the need to perform special assays for toxins. For example, botulinum toxin and gastric aspirates are stool samples. Blood cultures are often useful, particularly if salmonellosis or listeriosis is suspected, or when evaluation involves high risk groups and immunocompromised hosts. Let us discuss in brief description and treatment. Most foodborne disease is self-limited and requires only supportive care. The very young, older adults, immunocompromised patients and pregnant women may benefit from antibiotic treatment for certain bacterial or parasitic infections. Drug resistant pathogens require knowledge of regional, national and international patterns of resistance to allow appropriate empirical seldom of therapy. Conclusion: viruses and bacteria are responsible for vast majority of foodborne diseases. The time course of onset from ingestion to illness can be useful in establishing the cause. Certain food groups are associated with particular pathogens. Supportive care is sufficient for most cases, but antibiotics may be life-saving in others. Proper food handling, preparation and hand hygiene can prevent most foodborne illnesses. Thank you.